We're here at the 20th CROI with Michael Horberg, who is the director and the chair of the HIVMA. We really appreciate you taking the time to expose us to the issues around some of the politics and the science that's going on and some of the concerns that the organization of HIV doctors has to deal with. And I'm sure that money is a big one today.
Very much so, very much so. We want to get more patients into care. We want to get them in the quality care they need, including the medications they need, and keep them in care for the long term. However, the pie, for lack of a better term, of the monies available is not expanding. So how we're going to do this in an era of more limited, apparently, fiscal resources is a challenge.
So fiscally, this is an issue of, we talk about treatment as prevention. If we can manage to get the incidence, the new infection rate down through the herd immunity, so to speak, of treatment as prevention. In other words, the people that we know are infected, for gosh sakes, let's get them tested and get them into care and get them so that they are no longer as infectious and spreading the virus that they don't even know they have, or in some cases know and don't care. This is not right.
I think there are a lot of points on the engagement of care cascade, which is the term being used for it, that are important. So there is in this country 1.2-ish million people infected with HIV. Of those, only a certain number have been tested, probably about 80% of them. And so of that number, even fewer are in care. And then even fewer than that remain in care. So we need to get all those numbers up, because then we can get them on medication, get their viral loads down, stay down, and then that prevents the transmission of the virus. But you can't always go to step 4 if you haven't done steps 1, 2, and 3. And these things take resources, and part of it is engaging the community, making sure people know what's the resources available, making sure that there is quality care of access and access to the medications. A lot of this should get better with healthcare reform, but it's making sure that all these steps are in place for when the people actually start coming into the system.
And our population of those who are infected are not identified in one group. I mean, yes, there are certain groups that are found more likely than others, but so getting the message out is really kind of complicated.
Yeah. So, HIV is an epidemic in the United States still, so we know that it touches every community. Some communities tremendously more than others, but the key is to make sure that the people who have been tested in the past and who are positive, get them into care. And then the people who don't even know they're positive, get them diagnosed into care. So there's multiple steps. One is testing, getting everyone tested. Second is, getting the people who have been tested linked to care. And in this country, the problem is testing is here, care is here. And we need to marry the two, and we haven't done that efficiently in the past in a lot of systems.
Mm-hmm. Well, we've been preaching that and pounding that message out. Treatment and care is, and yet it's still, it seems to be, like you say, two different pockets.
In a way, for even in a lot of larger communities, it had been previously a very siloed operation. I think that's really changing. I think there's also a lot of systems, integrated care systems in the country where that hasn't been the case. And we need to learn lessons from that, like the VA, what they've been doing to get it there. But then it's not just getting them in the door, as it were, but then keeping them inside, keeping them there, returning for their visits, and getting the care they need. Because we know that there's a significant drop-off, I'm thinking, if the number serves me right, about 20 to 30%, between those who were engaged in care, brought into care, and then dropped out of care for whatever reason. Maybe they moved, health insurance status has changed, didn't like their doctor, didn't feel it was a warm, comforting environment. Maybe other financial circumstances, all of which or were incarcerated, let's say, all of those things lead people to be dropping out of care, and that's going to prevent also then effective care.
Some of the people in certain needful situations are, like you say, they don't have the choice because that's the way our system is today. So they have a one option. This is where you go if you're sick and you live in this area. There really isn't anything you can do about that. I guess that's just the way it is.
Well, and I think we need to also be a little clear about that. We've been in the healthcare system in this country very big about choice, making sure everyone had lots of options. But to me, the first and foremost important option is that there be good quality care. So if there's only one option, but it's a good Ryan White clinic or a very good VA clinic that's up to date, I would not view that lack of choice, or what's perceived as a lack of choice, is really a negative. Because even in those kind of clinics, there may be various choices of doctors, or there may be even nurse practitioners, physician's assistants who are well trained. So it's the perception that it's an all or none phenomenon, but it's probably not.
So you're talking about quality of services and provided and so forth. How do you evaluate, or how do you ensure that the people in your organization, first of all, it's there because you want to aspire to a better quality of care? How do you achieve that? What's the process?
There are lots of ways to do that. First and foremost, and obviously I'm a little biased towards the HIV Medicine Association, but also the AA, the American Academy of HIV Medicine. We have published criteria and definition of what a quality HIV provider is. The continued management of, in our case, 25 patients over 3 years, or at least within that practice, if there's shared responsibilities. Continuing education specific to HIV, and also some allowances or understandings that if you're in a low prevalence population
Right.
area, or if you're taking care of pediatrics where there may be fewer patients, and certainly maintaining these high standards for people who are both physician assistants, nurse practitioners. So there are set definitions. In addition, there are now quickly becoming key guidelines. The IDSA HIV primary care guideline lists very specific objectives and goals of what quality HIV care is. There's certainly the Department of Health and Human Services, the DHHS guidelines, that really give good indication of when to start, what medications to start with, potential drug-drug interactions, how to evaluate for success. Further, there are now set metrics of quality of care, including metrics that have come out from HHS that are going to apply across all agencies and really are also going to apply to even private healthcare systems as a uniform way of evaluating care. You know, getting people tested, what is the rate of linkage to care over a period of time, about 90 days? Mm-hmm. What is, once diagnosed, what retention in care? At least 2 visits a year over a 2 year, and measured over a 2-year period. So really a visit in every 6-month period over a minimum
yeah.
over a 24-month period. Getting prescription of ARTs, and then viral suppression, and including housing. So these are key concepts of and well accepted within the community. What is good quality care? Or maybe a better way to say, what would be the minimum standards of good quality care?
Now, we have an audience that's very diverse, as probably the disease itself. Could be and a lot of providers, a lot of people who like to learn about the science of HIV, about the operation of the work and the behind the scenes and the administrative issues that you talk about. What about the docs that are less than 25 patients? There's a doc watching now from the middle of Kansas that has 5 patients, How do you integrate him into what you're?
Well, I think there's a couple key ways. One is that they're aware of what the standards of quality care are. Not per se the number, but like talking about knowledge of the guidelines and where to go get those as references as you need them. Understanding what are the metrics by which a larger practice would be evaluated. And most of those you apply to every patient, achieving viral suppression, maximal viral suppression, getting patients on medications. And then even with the HIVMA definition, if you are in an area of smaller prevalence, we have it set up that we encourage strongly that they they have a path to mentorship, or certainly opportunities for mentorship, that in case they have questions. Fortunately for Kansas, two of the best HIV docs in the country are there. Dr. Donna Sweet in Wichita and Dr. Sharon Lee in Kansas City. So there is, even when you're in an area of low prevalence, there is easy access to real specialists. And I will say that certainly everyone who sits on the board of directors of HIVMA, our board is more than happy to serve as mentors, and certainly through our organization hook people up to get their questions answered, and sometimes even more than one.
That's what I was going to say, because sometimes when you're looking at a lot of new drugs, or there's a large number of drugs that people can take today, and how to manage to go through that process of even just the selection of a combo that might be right for the right person.
Exactly, and that's why even some of these guidelines have preferred agents for preferred combinations for initially when to start. And then if there is virologic failure and you get viral resistance testing, how to be able to interpret that. There needs to be people available that you can call on. There are some of us who can look at many patients in one day, and it's all second nature. But you're right. I think even newer providers who are starting the path, even if they're in an area of high prevalence, will need mentoring as you build up this experience. Knowing, well, for these kinds of patients, this drugs work better, or for these kinds of patients, I've got to make sure I get these kinds of preventive testing. Even more so now, as we have a graying of the HIV patient population, to say nothing of the docs. Yeah. We need to be, there are areas that we haven't always necessarily thought about as germane to HIV care. But as patients are getting over 50, making sure they're getting their colonoscopies, or certainly fecal immunohemoglobin testing to make sure that there isn't a potential chance of colon cancer, making sure women get their mammograms, making sure they get exercise and diet. These are whole areas that if we were having this interview in 1993, 94, we never would have brought up as topics. Mm-hmm. But now, fortunately, with effective treatments, we do need to talk about successful preventive health care. And maybe the biggest one, stopping smoking.
Right. Well, we talked about survival in the old days. Now we're talking about quality of life. And
we are still also talking about survival as you age.
There are, exactly, yeah, but there are people who are living better. There are still people living with the challenges of accelerated aging and AIDS, which comes in many forms and shapes.
Exactly.
So, but a lot of, and I think we've proven in the accelerated aging and AIDS meeting, or the aging meeting, that the smoking cessation is a very important part of anything. If you're smoking, that is a very serious problem.
It is.
It contributes greatly towards advancement of disease.
And we know some of the smaller sub-communities, for lack of a better term, that make up the larger HIV community, there is higher smoking rates than that's seen in the general U.S. population, which has been, fortunately, declining, although maybe not as precipitously as we would like it.
Well, our organization pushes strongly for nutrition and exercise education.
Terrific.
And using it. In fact, we have a program called Health Challenge, so we're trying to take that across the country, and actually did travel through Kansas doing those programs in Wichita and so forth. So, but there again, you find so many ways to improve the quality of life. I think for me that would be the biggest challenge. What are the biggest challenges for the HIVMA as an organization today?
So what we're seeing, a lot of the biggest challenges, one is getting ready for healthcare reform. We are going to be seeing a seismic change in how care could be delivered, certainly how care is financed, and seeing a larger, greater number of people have access to health insurance and care. And then so getting those providers ready for what they should expect, certainly some of these lessons probably will apply to even more so than just HIV for other complex chronic conditions. Getting then the patients enrolled, and then on January 1st, 2014, making sure there is good continuity of care. We're also concerned that there are going to be a bunch of patients who presently are, for example, are on Ryan White, and with especially the Ryan White Medical Home, it's been a very much all-encompassing care. We'll now be going to Medicaid or maybe even some private insurance plans, making sure that those patients get the care they need and that there's no drop-off, loss to follow-up, loss of access of medications. Further, this year Ryan White is up for reauthorization, and what should Ryan White look like in an era of new healthcare reform? And I think that's an important question that I don't think anyone has the final answer yet. Finally, another area that we're really interested in, that I think might be really also of interest to your viewers, is organ transplantation.
Yes.
As you know, organ transplantation has historically, HIV positive donors are not allowed to donate organs. HIV positive patients can receive organs, but only from HIV negative donors. With patients on virologically controlled, with patients who are already HIV positive, there's been a bill introduced in Congress that HIVMA has been very involved with called the HOPE Act. And its goal, it's actually got bipartisan sponsorship, which is these days in and of itself a true modern miracle, to change the law that they're permitting research and re-looking at the issue of HIV positive donors to HIV positive recipients of many organs.
Well, that's a wonderful goal or project, if you will. I appreciate you taking the time, and it's always a pleasure, and I hope that the viewers, if there's any references that you want to make to your organizational website.
So www.hivma.org.
Okay, good.
A lot of good resources, especially for providers.
And is this also for patients to seek providers?
Yes, we have good links there for that.
Okay, great. I certainly appreciate the efforts that you're making, and it's always good to have an organization behind the very important issues that we face today and the challenges.
Thanks so much.
Thank you very much, Doctor.